and sort of update all today about the work that the steering committee involved in, and take any questions if people have any. As you know, the Sepsis Network and many of you folks on the phone did a tremendous amount of work around the BC Adult Sepsis Guidelines, developing what those guidelines should look like, and developing the sort of QI metric and measures around those guidelines that all become a key component of the clinical care management initiative. And in July of this year, Dr. Sweet came to the CCM steering committee to sort of update the committee on progress and to just inform the committee of the work ongoing, and in particular one sort of area that he would like the committee to be aware of. And the CCM steering committee is typically made up of the VP medicines of the health authorities. Dr. Doug Cochran from the Quality Council sits on that committee, as well as my Assistant Deputy Minister, Barbara Karabik. And Dr. Sweet sort of presented the work, sort of the implementation progress going on across the province, and kind of touched on the challenges that the province was experiencing around particularly the lactate testing component of the guidelines, and the timelines associated with that lactate testing. And the steering committee sort of perked up and had a lively discussion around not only the importance of lactate testing, which I think we'll talk about some more today, but also the time frames that are laid out in the guidelines and how we can support the system to meet those timelines in a number of different ways. So coming out of that July CCM steering committee, it was decided that what we should do is really poll the province as to their capacity to test lactate within 30 minutes of presentation to triage. And we worked with Shari, Dr. Sweet, and some others to come up with some questions to ask the health authorities around their ability to test lactate. We asked, does your emergency department have the ability to test lactate within 30 minutes of presentation to triage, to provide results of initial lactate to clinicians within 30 minutes of blood draw, and to repeat lactate levels every 2 hours if initial lactate level is greater than 4. Those were the sort of core questions we asked the health authorities, as well as some questions in regards to the modality of testing. But we sent that out and got it back, and we were quite surprised by the responses we received. We generally received yes to our 3 core questions, that yes, we do have the ability to test lactate within 30 minutes. Yes, we do have the ability to provide the results to clinicians within that time frame. And yes, we do have the ability to test every 2 hours should we detect an elevated level. And when we got the results back, we kind of shared them around with the smaller group, and people sort of started raising some red flags about those results. So we checked back in with the health authority folks that we sent it out to. And in fact, yes, they did send it to the emergency department leadership. But perhaps in reality, we got a best case scenario response rather than what people were actually experiencing in their own emergency department on a day-to-day basis. So, I think we can have a little bit of discussion about why we got the response we did, but my sense of it is yes, our laboratory could meet the time frames outlined in the adult sepsis guidelines, but in reality there is a multitude of competing priorities, and you know, the experience of the field would say that that 30-minute window is actually quite difficult to meet. So getting the response back that we did, we said, you know, this probably isn't the end of the story. We need to sort of collect some more on-the-ground information to help the steering committee sort of tackle this problem around the province's capacity to test lactate within the timeline specified. And one of the ways to do that that's being floated is around point-of-care lactate testing, which I believe is in place in some areas of the province, and some areas it isn't. But the overall sort of policy question that the ministry is looking at, and that the CCM steering committee will also ultimately make a recommendation around, is should British Columbia invest more heavily in point-of-care lactate testing in regards to the sepsis guidelines. So the steering committee met again in October and sort of discussed the results that came back from the survey, and the members around that table also agreed that, you know, this probably represents the ability to do it, but in reality it's maybe more difficult, and have asked that we sort of pilot what point of care would look like at some select sites around the province. So that work is just kind of getting off the ground right now, but we've had a couple sites come forward to say they're interested in starting the discussion around what a pilot project for point-of-care lactate testing to support the sepsis guidelines would look like. And Shari's sort of involved in those initial conversations, and we'll definitely update this group once we have the sites nailed down and the sort of project plan around what the pilots would look like. So that's kind of my update, Shari. I'm happy to take questions, or you've been involved closely with all of this as well, so maybe you could fill in anything I've missed or give your perspective.
Yeah, thanks, James. I think I'd really like to just hear from the people out there in the health authorities, just around their thoughts around what the survey results, how they sit with them. Does that resonate with you? And maybe just share your thoughts around your ability to get timely lactate results back at your own site, and maybe dialogue around what's needed, what you think is needed to achieve best practice as per the BC Sepsis Guidelines. So whether that's process improvement, point-of-care testing, or just improvement in communication, et cetera. So maybe we'll just go quickly by health authorities so that we can have sort of an open discussion about this and keep it a little organized. Yep.
Shari, I was wondering just before we do that, I think that's a great idea. I'm just wondering if for everyone who's on the line right now, the 29 people that are attending, I wonder if we could just use a checkbox. So for people that think that at their center currently, they're able to get lactate measured within 30 minutes and a result to the clinician within 30 minutes for the majority of septic patients. Now, the current targets are going to be around 80% at least for all the severely septic patients with septic shock, and for the screening of all other septic patients, around 60% is a target, but those aren't defined yet. But why don't everyone check, just put a check beside their name. You can see it in the bar at the bottom of the screen. If you think your center is doing that consistently, and put an X if you think they are not doing that consistently or capable of. Great. We're seeing some results coming up there. Does everyone else know what to do there? I see a whole bunch. I see about probably 8 X's. And I see 1, 2, 3, 4 checks. Are the call-in users able to do that, Shari? I see a lot of call-in users that don't have.
Well, they're just not synchronized with their names, but I think we've got responses from pretty much everybody there. So what we're seeing is five people indicating yes, they're able to do that at their site, and the rest indicating no, they are not.
Okay, and now how about we open up to comments now? Any comments about all of this, or what you think you need or your department needs?
Go ahead, Claude.
Shelley from Penticton. Can I start?
Sure, Shelley, go ahead.
Okay, I was going to say that I think that, our department, I put an X beside our name because our department is absolutely capable of getting this done within 30 minutes. The problem is that the measurement is from door time, right, to lactate draw, and it depends what's happening in that department, because by the time they hit the door and by the time they get triage and by the time they see the nurse and the physician, depending on what C-test level they've had and what else is going on, it could be, it could be any amount of time to there. So the actual getting the lab to the ED is no problem. It's just when are they calling the lab, and that's where I think our delay is.
So do you think there that if you, for example, had a point-of-care lactate testing that could be drawn by the nurse, do you think that would be helpful? Do you think it would make a difference, or are the issues not related to that?
I think it would be helpful because it's a triage where we're identifying the potential sepsis patients and rule out sepsis. So if there was some kind of thing where that could be done as a standing order, I don't know how that would fly, if that can be done or not. But if it can be done like that, then possibly for sure. Or if the doctor right away, well, this is a rule out sepsis, let's just get that lactate now. Like I said, the lab is perfectly capable of doing it and more than happy to come stat, but I think it's a matter of when these patients are being identified and how quickly they're seeing the docs and stuff.
I will say there is a definite trend in the sepsis quality improvement work toward being nurse-initiated lactate draws for patients who meet the criteria. Just a comment. I see some other hands there. Brent, do you want to go next?
I just happened to have an example from yesterday. So the guy hits the door at 8:46. He's triaged by 8:49 and determined to be a sepsis-like illness, CTAS-2, stuck in a bed. The nurse-initiated order was at 09:07 by the time they got in the bed and ordered it, and it got transmitted to lab. And it was then the lab gets paged for a stat collection, but a stat for them has to be done within, here at Fraser, has to be done within 15 minutes of the page. And so then the blood was, well, we actually didn't meet that, did we? Blood was drawn at 9:30, and then it was probably reported about 10 minutes later. So then that's 60 minutes to lactate result from arrival. And this one was one that relatively fell into place on the triage bedside kind of communication and treating the sepsis. And so the lactate then came back at 4, and it would have been really nice to know that that person's lactate was 4 at, say, 08:50.
Right.
It's Claude here.
So sorry, before you go there, Claude. So Brent, do you think point-of-care lactate testing in that scenario would have sped things up more?
Yeah, it would have basically saved us 50 minutes on that patient, because the triage nurse had flagged, you know, this is a septic patient, and so then if they had the ability to do the testing, it would have got done right away.
Great.
It would be like a glucometer for the septic, is basically.
Right. That's sort of the way it's viewed in a way, like a glucometer for sepsis, as well as many other disease processes. Claude?
Yeah, thanks, Dave. Just firstly, a question. The 30-minute time, are we talking about from order to result or collect to result? Or from when they arrive at the department to result?
Right. So basically you want the clinician to have the information within an hour of arrival at triage. So the current guidelines
are within an hour of arrival to triage, but the 30-minute time that we were talking about was when I'm assuming when the blood was collected and sent to the lab.
Right, so there's two. So from triage, him hitting triage, to get the sample drawn within the first 30 minutes, and then you have 30 minutes to get the result back to the clinician. Now, we may make some variation on that. If we start to bring point-of-care lactate testing and whatnot, we may have to change that a little bit because really we just want the clinician within an hour to get the information. But the vast majority of places using the laboratory, it's not a turnaround time as quick as a point of care, for example. So the goal really is for the clinician to have the information within an hour, but because of the current way it's done in the province, we are asking for it to be drawn within 30 minutes, so you have that lag time of the blood going to the lab and getting analyzed and then the results sent to the clinician, if that makes sense.
So, yeah. So in Richmond, I think we can do that, but I don't want to speak on behalf of the lab, but we have been working with the lab on this. I certainly think a few more conversations will get us there. Having said that, I do totally support point-of-care testing. We've been talking about it for a long time for other things aside from lactate. The only issue that has come up, at least in Vancouver Coastal, has been the discussion around quality with the lab folks as far as the quality piece when it comes to point of care. As far as Richmond goes and the ED, if our lab supports it, I'd be more than happy to trial it here.
Oh, fantastic. Thanks, Claude.
It's James here. Can I just ask a question? I don't...
Sorry, can you silence Tammy there?
Yep.
Sorry, James, go ahead.
I don't know if there's anyone on the line from the north or the more rural sites, but I'm wondering about whether or not point-of-care lactate testing would actually change sort of the care plan in a more rural site that would tend to transfer these type of patients anyway. I don't know if there's anyone from the north or a rural location that could speak to the efficacy of point-of-care testing in their environment or their context.
Hi, it's Cynthia. So I'm the Regional Director for VCH for emergency, and in conversations with our rural sites, they have the ability during the day to get some of that information, to get the turnaround time done. But it's when lab isn't around, and so their point-of-care testing does and can impact how they treat a patient. So I think it would be helpful from their point of view. Claude's right. The conversations have been generated more around the quality of the results rather than actually resistance against going towards point-of-care testing. I think people are more than happy to go that way, but there has been the conversations around the quality of the result.
Without question, agreed.
Darren Abbey here. I wonder if I might make a comment.
Sure, of course, please do.
Yeah. Good morning, everyone. I think that first I'd like to just comment. I think that the data we collected as a province about, can we do this versus, is this what's happening for every patient? I think our scenario here in Nanaimo is we have the capability and many patients don't actually fall within those timeframes. So I think that was a keen observation. I'm wondering about a few things with point-of-care testing. I'm curious if you need a doctor's order for it. And I'm curious if there's systems out there that will allow some communication with a point-of-care machine, a lactate value, and communication with an electronic health record.
So, sort of first question you had there, so about does it require a doctor's order? Was that the question?
Yes.
Yeah, so just like any other testing that can be nurse-initiated in many of our departments, point-of-care lactate testing does not necessarily need a doctor's order. So it can be set up that it could be a nurse-initiated process. As far as the communication piece, this is something that we're obviously been working on, and I don't have a solid answer for you, but my understanding is yes, that with the ISTAT systems, they can be set up, number one, for excellent quality control, and two, that they can have communication with electronic patient record. Now, how that is entered is something I'm not 100% sure about. If you can have a direct communication between the system and whatever electronic record you're using, I'm unsure of. And it may have to be that it's actually entered by hand, for example, by the nurse, so they get the result in the emergency department, and there's a way they'd enter it and it'd be transmitted to the lab that way. But those are all logistics things that can be worked out in the future, but they are important for sure.
Yeah. I have one other logistic question, if I can. I wonder if that would free some of us up from the challenge of being able to use a blood draw from an intraosseous site.
Interesting. You know, I don't know the answer for that for sure. I'd go out on a limb and say that probably not, that an interosseous site would work in that. I don't know for sure, but my guess would be just the consistency and the quality of a marrow sample would be different than whole blood. And so I'd be the same way that I don't think you can just send an ABG from marrow sample, but I don't know for sure. I've never tried or asked the question, but it's a good question. Do you have any experience in that?
The only experience we have is that when we tried to do it, it wasn't received very well by our team.
I like the thought. But I'd have to check with the manufacturers to see if a marrow would work in one of their samples. But my guess would be probably not.
Cool. Thanks.
Thanks, Jim. Well, that was a great discussion there. Are there any final comments before we let James make a final comment?
It's Shelley in Penticton. I just had one thought. This is actually a dream, but it would be really nice if the systems that we have, if you had a lactate result that was greater than 4, somehow it automatically triggered the reorders for every 2 hours until the result came back, because that's the second part of meeting this goal that we're not meeting, is the every 2 hour draws. It would be nice if somehow the systems were smart enough to know to just come back in 2 hours to redraw.
I could not agree more. And this is something that we've had in discussion with different laboratory physicians and different health authorities. And I really still think this is something that's possible. And if within VCH or PGH specifically, we've had some discussions with this with some of our quality people. If we ever figure out a way to make it work, we'll make sure that we share it with the network.
I have a similar question, if I can. It's Darren Abbey here. I'm also curious about if there's a way that our systems can treat this as an important value, important enough that it would necessitate communication with caregivers. Like similarly the way we do with a troponin or a white blood cell count. In our shop anyway, a critical value doesn't get called in as we've talked about before.
See, within our shop it is. And so that is something that you can talk with your lab about and have that made a critical value. All of those call in most of the time from labs, for example, a change in hemoglobin, an absolute hemoglobin number, a troponin level. Those are all set by the labs in the individual center. So having a discussion with your lab group would be the easiest way to make an automatic call in or reporting to the nurse at the bedside for any value. Excellent. James, any final comments?
No, I think I would just thank everyone on the line for their insights. It's a really exciting project from my personal perspective, and I look forward to seeing some of the pilots get off the ground and just reporting back to this group about what we're learning through that process and sharing as much as possible as we move forward.
Excellent. Thank you so much, James, and thank you for attending this call and taking the time out of your day. We really appreciate it. It means a lot to us as we're all passionate about this topic, as you can imagine. And if anyone is interested in being a possible pilot site, make sure you contact Shari or myself, and we can pass it on to James as we go forward with the pilot projects for point-of-care lactate testing. Thanks a lot, James.
Yeah, and if anyone has follow-up questions or was wondering how their site responded to the survey or anything like that, please flip me a note. It's james.watson@gov.bc.ca, and we'll definitely answer any questions people have out there.
And maybe we'll just type that out, Shari, into the chat to the all group so people can write down James's email if they want to contact him. Thanks again, James.
Okay, have a good day. Thanks, everyone.
Thank you. Okay, guys. Well, now I'm going to go right into the presentation about lactate. What I've done today is I've gone through some of the literature around lactate and sepsis and actually put some new additions in that have come over the last couple months. It's 9:42 now, and we're supposed to go to 10:15, so I'll try to get it done in the next half hour. I'm sorry if I'm a little bit quick in some areas that we've talked about before, but I'd like to get some of this new information out because I find it interesting. If I do go over a little bit, we won't stop the call. Feel free to stay online. I think that's correct, Shari, right? We won't get kicked off right at 10:15, will we?
That's right, yeah.
Excellent. Okay. Well, when we all got together and met for the first real day of the BC Sepsis Network and designing the BC Sepsis Network, one of the comments that came out is that a key to moving forward is timely lactate measurement, and that's why we find ourselves here today and why we've been in discussion with the ministry on how we can improve our lactate testing across the province. As I've shown before, we know that knowing the lactate of a septic patient is very important as they have extremely high mortality. In a study from 2010 looking at 15,000 patients, you can see that the mortality is excessively high for patients that have a high lactate and ones that require vasopressors between 30 and 45%, which is really a higher mortality than the vast majority of disease processes we see in the emergency room. Over time, the number of patients that have been presenting with sepsis has increased. Now, this probably has to do with several factors based on drug-resistant bacteria, different amount of immunosuppressants in the community, as well as likely the way people are recognizing sepsis, and now we're more cognizant and report it more often. But you can see there from 2000 to 2008 that the rate of sepsis and MI admissions is significantly more for sepsis, and it's even more now. We all know about the continuum of the disease from SIRS to sepsis to severe sepsis and septic shock. And one of the reasons lactate really is so important is that maybe about 10 years ago, the way we define severe sepsis used to be based on multiple variables, including white counts and platelets and coagulopathy and organ dysfunction. But it's really come down to now that people primarily look just at an elevated lactate, because this is a marker of the severity of sepsis, and it's easy to identify patients. This also obviously will progress on to septic shock with time. And again, the literature shows us that these are the two groups that we really are interested about, and early interventions likely improve the outcomes in these patients. And those therapies, as we said before, are the easiest stuff, just the cheap, quick stuff, being antibiotics, fluid, cultures, and repeat lactate testing. Now, when you look at the Sepsis Guideline for BC, these are them basically in very short form. Half of them pretty much involved lactate testing. So initially being able to identify patients very early to see if their lactate is greater than 4. And the second point, that if it is elevated, we want to repeat that lactate. Number 1, for prognosis, and 2, to know if our therapies are being effective. Since the 90s, over and over again, it's been shown that lactate levels greater than 4 are a univariate predictor of mortality. And what's sort of interesting about this is that the reason why someone with sepsis has an elevated lactate is variable. It's basically too much production or not enough clearance. Not enough clearance usually is that there's some degree of liver dysfunction, and therefore the lactate's not being metabolized, which does happen in severe sepsis septic shock, or increased production. And the two methods that you have increased production generally are decreased oxygen delivery to tissues in the body, and therefore cells switching to anaerobic metabolism. And 2, increased production through enhancement of the glycolytic pathway in a stress response. So as the body releases catecholamines, as it's becoming more unwell, the glycolytic pathway is revved up. There's an abundance of pyruvate, and then rather going into the Krebs cycle, it gets shunted to lactate because there's so much production. But what's interesting is without teasing out why your lactate's high, either being increased production from those two means or decreased clearance, it works out the same. They're all bad, and they all suggest that you're going to have a high mortality. Back in 2005, this is a study in the emergency department looking at patients with infection, and as you can see, as your lactate increases on presentation, your mortality goes up. And once it hits 4, there's a significant logarithmic increase in mortality. Now, it is interesting to note, and it's been focused on more in about the last year, that even these people that have these small elevations in lactate do have an increased mortality. If you look at the group between 0 and 2.4 and 2.5 to 3.6, The absolute mortality is still relatively low compared to greater than 4, but look at the differences in relative mortality. So even those small increases show almost a doubling of mortality. So maybe we should be looking at these people even closer than we are now. Now, looking at lactate testing in severe infection has been done in almost every clinical scenario. This is an example of one done using point-of-care lactate testing in Uganda for patients with severe sepsis, and in exactly the same way that we see here in the first world studies, that a lactate greater than 4 has a 7-fold higher mortality than a lactate less than 4. This has also been done pre-hospital, so looking at ambulances and patients on lactate levels. We see something very similar. So patients with a lactate greater than 3.5 compared to less 3.5, significantly higher mortality. And something that's interesting here that I want to point out, and I'm going to talk about a little bit later on, is that if you have a low lactate, even though you're in shock, your mortality seems to be a lot lower than if you have a higher lactate. So there you can see on the x-axis the systolic greater and less than 100. They have almost the same mortality even if your lactate's less than 3. But if you look at the patients with a lactate greater than 3.5, they have a significantly higher mortality if you have both a very high mortality. And this patient group here is one that we're always concerned with, the ones with a normal blood pressure and a high lactate, and they have a very high mortality. And if with us we're doing our early lactate measurements, we're never going to find these patients. Another study in the emergency department looking at lactate. And again, we have mortality on the y-axis, we have systolic blood pressure on the x-axis, and lactate on the on the x-axis, z-axis, sorry. And again, what I really want to point out in this picture is the two boxes on the far left and the far right, that the one that has a normal blood pressure, a systolic greater than 90, but a lactate greater than 4, has around a 15% mortality. But then you look at the patient with a low lactate and hypotension being less than 2.5, and the first two boxes there, the 70 to 90 and 90, have lower mortalities. But then the patient with a systolic less than 70 has a very similar mortality to the patient with a high lactate and normal blood pressure. For more clinicians, you'd know that a systolic less than 70 is pre-arrest. So when you get with your systolics in the 60s, a lot of us are thinking about giving some epinephrine at that point in time, push, because they're likely going to arrest. And it's amazing that these people have the same mortality as someone with a normal blood pressure, maybe sitting there talking to you about a lactate greater than 4. Now, to emphasize again the importance of this idea of cryptogenic shock or the normal blood pressure and a high lactate, this is a study published last year from the Jones group looking at patients that have cryptogenic shock or a normal blood pressure and a high lactate, and patients with overt shock being hypotension. 300 patients with severe sepsis and septic shock are presented to the emergency department. After controlling for age, comorbidities, and severity of illness, we see this graph that overt shock and cryptic shock have about the same mortality. So a normal blood pressure and a high lactate will have even a higher mortality based on this than patients that are in overt hypotension and shock. That difference is not statistically significant, but they're obviously about the same mortality. So we do need to identify these patients and identify them early. An interesting study published just this year, and this concept coming out now about if you don't have a high lactate, are you really in septic shock? So looking at patients that are septic and hypotensive, but look to see if they have a high lactate or not. And this is what they found. So on the y-axis there, you see the survivability, and these are all patients in shock or hypotensive. And you can see that if your lactate is less than 2.5, 92.3% of them survived. If your lactate is greater than 2.5, only 57% survived. P-value very significant. So more and more we're starting to hear that, well, you know what, if you're in the emergency department with sepsis and you're hypotensive, so low systolics, but your lactate never goes up, so you always have a normal lactate. And we see these patients, they're usually warm. Their body is compensating for that hypotension. So even if they're hypotension, their cardiac output is obviously enough. They're getting oxygen to cells. They don't have a significant stress response that's causing lactate production to the glycolytic pathway, and their liver is functioning fine. So in fact, maybe your lactate level in the clinical scenario is almost more important than your actual vital signs. Interesting idea. Because of what we've stated previously, the importance of identifying patients early, you can see that that's in our guidelines that we want a lactate measured within 30 minutes and the result to the clinician within 30 minutes. Sorry about that animation. We're having transmission issues between Mac and PC. So we want a rapid turnaround time, 30 minutes getting back to the clinician. And finally, if your initial lactate is elevated, we want it repeated in 2 to 4 hours. Well, why is that? Studies back from early 2000 have been looking at lactate clearance and its outcome in severe sepsis and septic shock. In this graph that I've shown before, that looked at a 10%, just a 10% clearance of lactate, that if your lactate cleared less than 10% compared to more than 10%, significant differences in mortality, almost doubling in the patients with septic shock, and with severe sepsis, a significant step up. So we do know that patients that don't clear their lactate have higher mortalities. What other data do we have to show this? Well, this is a study, again, published in 2010 by Nguyen, who is the second author on Rivers trial, looking at lactate clearance and all these other factors that may contribute to mortality, so markers of inflammation, coagulopathy, apoptosis, and organ dysfunction. And what he did is he took all the patients that he had in his trial and divided them up in quartiles, so highest lactate clearance, second highest quartile, third highest quartile, and the worst quartile for lactate clearance. And across the board, we saw reductions in all these anti-inflammatory and coagulation markers, so IL-1, IL-10, D-dimer, and caspase-3, a marker of apoptosis, were all significantly less in the patients that cleared their lactate well. And in all the organ scores and severity of illness scores, so APACHE-2, the Simplified Acute Physiology Score, Modified Organ Dysfunction Score, and Sequential Organ Failure Assessment Scores, all were significantly better in patients that cleared their lactate in that highest quartile. So there's biochemical evidence that the body's doing better if it's clearing its lactate. Again, in that same group, looking at mortality, so mortality on the y-axis there, so the patients that cleared their lactate in the least quartile had a significantly higher mortality than the ones that cleared their lactate the best. Another study done recently showing they've looked at all these different aspects of lactate and base excess and tried to determine which one was the most predictive of a bad outcome. So this is a raw curve. The line right in the middle of this curve basically suggests 50%, or that test is the same as flipping a coin to see if they'll live or survive or live or die. And the closer you get to it bends to the left upper corner, the more sensitive and specific a test is. So when we looked at excess baseline lactate shock index map, actually the 2-hour lactate clearance was the best at predicting survival. Now they used 15% in this study for some reason, but that was the most sensitive and specific at predicting mortality. So it's definitely giving us information. The lactate clearance of a cutoff of 10% in many of the previous studies have been found to be the most sensitive, specific for predicting in-hospital mortality. So there is an inflection point around that 10% relative clearance. And that's why in our guideline, we've recommended that if someone is not clearing their lactate by 10% in the first 2 to 4 hours, they should have escalation of care, be in consultation with ICU, they should have more invasive monitoring, and be watched a lot more closely compared to the patient that clears their lactate more than 10% in that first 2 to 4 hours, that your therapies are obviously working in what you're doing. What's interesting is that maybe that 10% isn't all that matters. This is a publication that's still online just 2 months ago in CHEST, so it hasn't actually been published on paper yet. But what they did is they looked at the Jones group again, looked at actually the lactate kinetics in patients requiring quantitative resuscitation. And this is, again, one of those rock curves looking at sensitivity and specificity. And you can see all of them aren't as good as the previous one. But they're looking here at initial lactate, relative lactate clearance, absolute clearance, and clearance rate. So they're looking a lot more in detail at the actual kinetics of the lactate clearance. And as you can see in this graph, the one that still was the best, even though not great in this graph, was relative lactate clearance. So it's not the absolute number, it's not the rate at which it clears, but it's in the first 2 to 4 hours, the relative clearance that they have. Here, what I want you to focus on first is in the far left-hand side where it says variable. Now, this graph, or this table, what they're showing is patients that had a lactate normalization. So no matter what the initial lactate was, if in the first 2 to 4 hours it totally normalized, compared to right below that, they had a relative lactate clearance of 50%, below that, relative lactate clearance of 10%, and at the very bottom, initial lactate of 2 to 4. And what you can see in that green box is, in fact, this is the odds ratio of survival. So if you had normalization of your lactate you had a 6.3 more likely chance of surviving, 50% 4.3, and that lactate clearance of 10% just 1.7. So even though there is an inflection point to that 10% lactate clearance, the more you clear your lactate, the better you do. So if there is a goal that we're shooting for, 10%, that is an important number, but the more you clear your lactate, the better you're going to do, and that makes sense. All we've talked about so far is just prognostication, using lactate clearance to predict if someone's going to live or die, and to predict, and to assess if we should escalate their care or not. But can we actually use lactate clearance as a goal? So when we're actually resuscitating someone, can we actively try to improve their lactate as a goal? 2 studies that have been done looking at that. This one back in 2010 using lactate-guided therapy in intensive care unit this time, multi-center randomized controlled trial, 348 patients. And what they compared was looking at the central venous oxygen sat, which is when you put the central line in above the diaphragm. You're looking at the blood returning to the right side of the heart and looking at the amount of oxygen on it. So if there's very little oxygen on the blood returning to the heart, it suggests that the peripheries had to use a lot more up, but we need to augment the oxygen delivery. The treatment group, they did look at SVO2, but they also looked at 2 Q-hour lactate clearance, trying to clear it with 20% every 2 hours. And they did this with a complicated algorithm. Now, what they found is that in addition, trying to clear someone's lactate actively, that you had a lower mortality, 33.9% versus 43.5%. And you can see the Kaplan-Meier curve there. Now, the p-value did not reach statistical significance, but there was a trend of 0.07. The next study I'm going to talk about is probably the most important study to know besides the original Rivers trial in my mind. It was the one done in 2010 by the Jones group, who have done all these sequential trials we've been talking about. And what they did was they did a multi-center randomized trial with 300 patients looking at non-inferiority of central venous oxygen sat, what Rivers used, the blood returning to the right side of the heart, and trying to improve that compared with lactate clearance of just 10%, so doing one or the other. And they found no difference. So they concluded in their trial that looking at lactate clearance and resuscitating the lactate clearance was as good as the Rivers looking at the early goal-directed therapy, looking at central venous oxygen sat. Some important points to note about this group. 221 of the 300 did require vasopressors, so a pretty sick group. 80 got mechanical ventilation, so again, not quite our ICU population, but if you look at all the patients that come in, hypotensive or with a high lactate, I'd say probably about that, around a third may get intubated, and the other ones we resuscitate before they get intubated. But what's interesting is only 29 of those 300 required dobutamine or packed red blood cells to either clear their lactate or to improve their SCVO2. And this is much different than the Rivers group, which is thought to be a very sick patient population that he studied. And this is more consistent with what we see in the emergency room, that it's pretty rare that we're adding dobutamine or giving red blood cells because of a high lactate or a low SCVO2. Now, this was just published in March of this year, that same trial I was just talking about, and they looked at some of the little smaller components within that trial. So they wanted to look specifically at the prognostic value and the agreement of if you clear your lactate or if you improve your central venous oxygen sat, and which one's more important. And what they found is actually interesting. So what they found is that of this 203 subjects that they put into this subgroup, that achievement of your SCVO2 goal was associated with quite a high mortality rate still, 41%. So basically, if your lactate didn't get any better, but your SCVO2 goal did get better with therapy, 41% of the patients still died. Well, achievement of the lactate goal, clearing it by 10%, but you didn't improve your SCVO2 goal, mortality rate was 8%, very low mortality. So what they concluded that there was no agreement really found between lactate clearance and correcting your SCVO2 goal in early sepsis, but achievement of your SCVO2 goal without achievement of your lactate was more strongly associated with mortality than the other way around. Achieving your lactate, but not achieving your SCVO2 goal greater than 70, which is fascinating because what this suggests is that actually normalization of your lactate is more important than normalization of your SCVO2. So really maybe looking at lactate and watching lactate clearance truly is the marker that we need to be watching and trying to correct. This is why we need to measure the lactate so that we can provide the therapies that we know have been shown to improve mortality. All of the studies looking at sepsis protocols in the emergency room have used either hypotension after fluid or a high lactate to be entered into the trial, and across the board we see significant reductions in mortality. Many of those significant reductions in mortality have been associated to getting early antibiotics in and getting early fluid in. Now, because it's so uniformly accepted that this is important, there haven't been a lot of studies that have actually looked at the benefit in a high lactate group of giving them fluids and giving them antibiotics early compared to the shock, because they're always grouped together. But this is just an example of, again, the Jones group looking at their study, 300 patients that were on an aggressive resuscitation algorithm, and they looked at delivery of antibiotics with respect to the diagnosis of shock, which either be a high lactate or low blood pressure. And as you can see here, that if the patients got their antibiotics before they were defined as shock, being lactate or hypotension, compared to after the definition of shock, there's a doubling of mortality. So we do know that for sure there is a significant marker there that we need to get antibiotics in early in both these patient groups. Now, within Canada, we've done a survey asking about sepsis care, and again, I want to point out, I know I've shown this slide before, that what concerns me the most is our rural centers. So you can see here at the bottom, the red circle, that out of the 20 rural centers that we spoke to, that only 6 of them were able to get these lactate measurements. And I hope I've convinced you that the importance of being able to measure lactate early. Conclusions of that study were that the ability to measure lactate needs to be supported by our hospital infrastructure. We need to support our rural communities in the ability to measure lactate, as well as our larger centers that are incapable of doing it now. If you have any questions, you want to read more about this, the vast majority of this information, except for the new literature, is in the BCMJ article that we published. We talk a lot about lactate testing there, so if you want to look that up, feel free. Summary: sepsis protocols improve mortality. We know that for sure. Early identification is paramount. We need to measure lactate quickly to identify. We need to be able to repeat lactate measurements so that if patients are not clearing their lactate, we can escalate their care. We need to support all our hospitals in the ability to measure lactate. And this leads to our vision statement, and I really truly believe this is that for sepsis, we want the best sepsis care no matter where. So this is something I really believe that is not technology driven, that if you're anywhere in BC and you have severe sepsis or septic shock, you should be able to get the same cares if you're right downtown Vancouver. Thank you very much. Now, I know that was a lot of information, and I tried to go quick for the sake of time. I wanted to give us about 10 minutes of discussion if we need it. Any questions on any of that stuff or any comments? Seeing some names pop up. Is anyone there trying to say a comment, a question?
Here from Prince George. I'm wondering, are any of the guidelines changing now in terms of clearance instead of the venous oxygen saturation?
Sorry, I didn't get that totally. Can you say that one more time?
Are any of the guidelines changing because of the lactate clearance you haven't presented?
Mm-hmm. Yeah, it's a good question. So, sort of the more international guidelines, well, an update of the Surviving Sepsis Guidelines should probably be coming out in the next month or two. I've had some preliminary reports about them, and in fact, I think what they are going to be recommending is that I don't think they're going to remove early goal-directed therapy and central venous oxygen saturation until some of the larger trials, such as PROCESS and PROTECT, are going to be published in the next couple of years. So I think early goal-directed therapy and looking at central venous oxygen saturation is still going to be within the Surviving Sepsis Guideline. But what I've heard is that in fact they're going to replace or add on that lactate clearance of 10% is a reasonable alternative goal if you do not have the technology or ability to measure central venous oxygen saturation. So there is a trend moving towards lactate clearance, but I think until the really large international trials, which are ARISE and PROCESS, are published in the next year or so, I don't think we'll see a definitive change in any of the international guidelines. Does that make sense?
Yeah.
But I can tell you that, many of the other communities around the world that are doing the same thing as us, the vast majority have realized that putting in central lines in the emergency and doing central venous oxygen saturations is very laborious, and doing lactate clearance is not. And so the vast majority are accepting lactate clearance as a reasonable goal. And I really think that's the way we're going to go. I think my guess is in the future there's going to be a very small subset of patients that are going to require central venous oxygen saturation monitoring. And my guess is going to be those that do not clear their lactate. It would be really interesting to see if someone did that trial. To start off with lactate clearance, if it is clearing by 10% every 2 to 4 hours, continue with what you're doing. But then if your lactate clearance is not improving, taking those patients, putting in the lines, doing more invasive monitoring, either through looking at central venous oxygen saturation or some other form, maybe doing pulse pressure variation and pico monitoring, and try to determine what the cardiac output is. Is there anything else that we can do to assist them in their physiology, in a sense, and to see if that's going to be a benefit. I think that's the next big trial, because I actually think the days are gone putting central lines in every patient that comes to the emergency with a lactate greater than 4. It's just not done. It's not feasible, and I don't think the literature right now is strong enough to say we have to do that.
Are the lactate clearance, are you automating those calculations, or are you just doing it manually?
Manually. I would love to see it automated. So if the lactate ever comes back at 4, the lab automatically does one every 2 hours until it's less than 4 or less than 2, whatever you want to set it. But that's going to take some work. But that is the ideal, right? Because then over time, when internal medicine picks up the patient from the emerge doc, automatically they're going to pull up like 2 or 3 hours later and see, wow, look what this lactate is doing. It's doing great, or it's not doing great. Should I talk to ICU? That really is where things have to go, and we just have to figure out a way to make that happen.
Great. Thanks very much.
Okay.
Dave, there's a hand up from Sean Wormsbecker.
Sure, Sean.
Hi there. Should we be setting a lower threshold for getting our ICU colleagues involved based on some of the numbers you're telling me? Like, say if I have the patient that maybe looks a bit more unwell but only has a lactate of maybe 3, do you think that across the region people will want to admit these people to HAU, or should we still be waiting on our repeat lactate and trying to calculate the clearance?
Good question. I actually think it's okay to not include these patients, what you're saying. Like, I know that the numbers and the mortalities are high, but we have to remember that these are very broad groups, such as patients with malignancy, palliative patients. They're not all young 25-year-olds that come in, right? And so I really think if someone comes in with a lactate of 3, you're giving them a couple liters of crystalloid, their hemodynamics improve, their lactate clears and is going in the right direction. I think it's okay to continue along that pathway with antibiotic source control, repeat lactates, and be able to go, for example, to the medicine wards. I think that, you know, critical care is a limited resource when it comes to HAU or to ICU, and for those HAU is a high acuity unit, so a step-down unit, if you will. I think there's more to it than just a number, and I think that if we took all patients that arrive with a lactate greater than 3, irrelevant of the scenario or how they do with their initial resuscitation, I think we'd overwhelm our step-down units and our ICU units, and I don't think there would be real true benefit for that patient group. Now, if your lactate's not clearing or there's other clinical evidence they're deteriorating or not improving, I do think an ICU consult is warranted. Because sometimes 2 heads are better than 1, and you guys together might look at it and be like, oh, I don't know, this guy has a high chance of going south, so maybe we should watch him in the HAU overnight. But at this point in time, I'd say the emerge looking and internal medicine looking at the initial resuscitation, the initial lactate clearance, I still think that if it is improving, I think continuing with what people are doing is probably appropriate. But that's just my 2 cents.
Thank you.
And things may change too in the future, Sean. Like, there are more and more, like, you know, if you look at Surrey right now, like, they're going to have up to 50 step-down beds, right, in the new tower. So as we get more resources for things like step-down, it may be more and more reasonable to do these things, like having a monitor bed overnight in a step-down unit, and if you do look great, to move out to the hospital ward. But, for example, right now, in many centers where there's, you know, maybe 10 beds total in HAU, taking patients that look well, that have improvements in lactate, that just came in with a number of 3, I think we'd be using those beds up and not being able to treat other patients that need to be in there. So it just depends on what the future looks like and the resources that are available.
Perfect. Thank you.
Thanks, Sean. Any other questions, any other comments? And again, if there's anything in there that you went too quick and you couldn't see the actual reference to the paper, or you want any of those papers, feel free to write me. I'm more than happy to send those out, and we can have this lecture posted on the internet as well, so you'll be able to watch it again if there's anything you didn't catch the first time around. Any final questions? It's your last chance. Excellent. Okay, guys. Well, thank you very much for attending. I might put one final plug-in for people in the network to join Q Exchange. It's our online community of practice where people can interact and ask questions about sepsis. We have discussions going on. Maybe, Shari, could you put the link for Q Exchange up here quickly on the chat box right before we go so people can see it and maybe go check it out? I really think that this is going to be the future of our network and our ability to interact with each other and just share resources and questions. So please, if you can, join Q Exchange, go check it out, check out the sepsis sections. Great. Okay, well, I'll make sure to send out a notification about our next meeting, our next online lecture. And if you have any topics that you're interested in, please write me. I'd be more than happy to put talks together for you guys on topics that you're interested in. Thank you very much. Shari, any last words?
No, I think that pretty much covers it. Again, if you are interested in a point-of-care lactate trial, please contact us at sepsis@bcpsqc.ca. And if you have further comments for James Watson, his email is in the chat.
Great.
Thank you.
Everyone have a great day.